Hey everyone, welcome back to Shock Doc Medical. I'm Dr. Rod, and today we've got a killer episode for you. Have you ever wondered how a single, seemingly simple rash in a really sick patient can send you down a rabbit hole of diagnoses? Trust me, it's wild. We're diving into the clinical labyrinth of a generalized rash in a sick patient, a scenario that can leave even seasoned docs scratching their heads. So grab your coffee, get comfortable, and let's break this down like we're chatting in the break room. All right, first things first, when you see a patient with a generalized rash, there are some must-ask questions. Ask yourself, has the patient been traveling? Are they immunosuppressed or on any medications? And of course, do they have a fever? These questions help set the stage for narrowing down our differential diagnosis, which, spoiler alert, it can be pretty broad. Let's start with a generalized erythematous rash in a sick patient. This isn't just any red rash. It can signal several serious conditions. One big player here is DRESS, which stands for drug rash with eosinophilia and systemic symptoms. This reaction can be triggered by medications, and although the article doesn't list specific treatments, in practice we often consider stopping the offending drug and sometimes using systemic corticosteroids. For instance, prednisone at about 1 milligram per kilo a day is a common starting point, tapered over time, but always tailor it to your patient. Then there's the possibility of infection. There's a whole box of them we'll get to in a minute. But don't forget conditions like erythroderma, where the skin becomes red and scaly. This can be secondary to drugs, eczema, psoriasis, or even T-cell lymphoma. And sometimes, get this, it can be idiopathic. And then, if you see facial involvement, think acute GVHD, graft versus host disease, rather than a simple drug reaction. And yes, we also have to consider early 10 or toxic epidermal necrolysis, plus toxic shock syndrome, which can be rapidly fatal. Man, this list is intense. Now, what about an anaphylactic reaction with urticaria? We're talking about a rapid, severe allergic reaction. Think drugs, venoms, or foods. In those cases, the treatment is pretty standardized. You want to hit them with intramuscular epinephrine, usually about 0.3 milligrams for an adult right away, followed by supportive care. This is the kind of scenario where every minute counts. Moving on to purpura in a sick patient, this is where you see extensive, irregularly outlined ecchymoses, bullae, and even gangrene. When you see something like this, disseminated intravascular coagulation, or DIC, often presenting as purpura fulminans, should jump right to the top of your list. One red flag? Ask yourself, does the patient have meningococcal septicemia? But that's not all. Other possibilities include infections listed in one of our upcoming boxes, or even small vessel cutaneous vasculitis secondary to infections, drugs, or systemic vasculitis. And yes, sometimes a drug reaction like DRESS can also show up with purpura. All right, now picture a patient with widespread blisters and/or erosions. This is where your clinical detective skills really come into play. First, always check the mucosal surfaces, ocular, oral, and genital, for any blisters or erosions. If the blisters rupture easily, leaving behind erosions, you might be dealing with staphylococcal scalded skin syndrome, SSSS, Stevens-Johnson syndrome, SJS, 10, DRESS, acute GVHD, or even pemphigus, which, by the way, can be triggered by drugs like ACE inhibitors. On the flip side, if you see tense blisters, bullous pemphigoid should be on your radar, though typically those patients are systemically well unless there's a secondary infection. And don't forget, sometimes these blisters could be from a generalized herpes simplex infection, often seen as eczema herpeticum, or herpes zoster, where vesicles evolve into pustules and then crust over. Now let's talk about generalized pustules in a sick patient. One possibility here is herpes simplex infection in atopic patients, also known as eczema herpeticum, where those vesicles evolve into vesicopustules. Chickenpox or varicella zoster infection follows a similar pattern with vesicles turning into pustules. Bacterial infections can also cause widespread pustules, but if you see sterile pustules, think about pustular psoriasis or acute generalized exanthematous pustulosis, AGP, which is usually secondary to drugs. All right, folks, here comes the deep dive into our boxes of infections that can present with a morbilliform or measles-like rash and fever. In box 4.2, we have a list that includes measles, rubeola. Remember, this one also comes with cough, coryza, and those tiny Koplik spots on the buccal mucosa. Rubella, German measles. Erythema infectiosum, parvovirus B19. Look for the classic slapped cheek appearance in kids. Roseola infantum, HHV6, also known as exanthum sabitum, it primarily affects children. Enterovirus, often presents with pharyngitis. Infectious mononucleosis, EBV. Note that about 90% of patients with EBV who are treated with antibiotics like amoxicillin develop a rash. Leptospirosis, acute retroviral syndrome, HIV. Secondary syphilis, usually appears weeks to months after the initial chancre. Typhoid fever. Watch out for vomiting, diarrhea, and pink papules on the trunk. Those are your rose spots, and cultures might yield Salmonella typhi. Streptococcal scarlet fever and staphylococcal toxic shock syndrome also make the list. Now, if your patient has been traveling, Box 4.3 has got you covered with infections that can cause a morbilliform rash and fever. Chikungunya fever. Think Asia, Africa, or the Indian Ocean region. Dengue fever, common in Southeast Asia, Central America, South America, the Caribbean, and even parts of the Southeast USA. West Nile virus, found in Asia, Africa, Europe, and the Southeastern USA. Onyongyong fever, mostly in Sub-Saharan Africa. Mayaro virus, seen in South America. Sinbis virus, it pops up in Europe, Africa, Asia, and Australia. Ross River disease, found in Australia, Papua New Guinea, Fiji, and Samoa. Finally, Box 4.4 gives us the rundown on infections that might cause a purpuric rash and fever. This list includes meningococcal septicemia, a true emergency. Rocky Mountain spotted fever, seen across North, Central, and South America. Dengue fever, yep, it shows up here too. Viral hemorrhagic fevers, these can be due to various arbovirus or arenavirus infections. Yellow fever, found in Sub-Saharan Africa and the Amazon basin of South America. Epidemic louse-borne typhus, leptospirosis once again, and atypical measles completes the list. Wow, so much to take in, right? What we're looking at here is a comprehensive guide to the differential diagnosis of a generalized rash in a sick patient. Whether it's a drug reaction like DRESS or a life-threatening infection such as toxic shock syndrome, every detail counts. As doctors, we need to remember to assess travel history, immunosuppression, medication exposures, and the presence of fever. And when it comes to rashes, the morphology, whether it's erythematous, purpuric, blistering, or pustular, can give us huge clues about what's going on underneath. Now, I know this can feel overwhelming, but think of it like a puzzle. Each piece, from the patient's history to the specific characteristics of the rash, helps you see the bigger picture. And if you ever need a refresher on dermatological emergencies, remember, there's a whole chapter dedicated to that in your trusty textbook. All right, friends, that's a wrap on today's deep dive into the world of generalized rashes in sick patients. Whether you're a seasoned practitioner or just starting out, I hope you found these insights as eye-opening as I did. Remember, early recognition and understanding of these rashes can literally be life-saving. If you have any thoughts, questions, or just want to share your own experiences with similar cases, hit me up in the comments below. Let's build this community of curious, passionate minds together. Don't forget to like, subscribe, and share this episode with your colleagues and friends. Next week, we're uncovering another groundbreaking discovery that might just change the way we practice medicine. Until then, I'm Dr. Rod with Shock Doc Medical. Stay curious, stay informed, and keep pushing the boundaries of what we know about medicine. Catch you on the next one.